Good afternoon, everyone. Hope you're good and hope you can hear me. There's a bit echoey in here. This is room 3 at Choose Health HQ, and I don't think I've ever streamed from here. I'm having to hotspot a little bit because the Wi-Fi is a little bit laggy, so hopefully you're still getting me. And it's a little bit echoey, but I hope you're going to forgive me that. Part of the reason for that is because I've not got the fancy ass mics and stuff, so I'm just going with an echoey room. But the topic should be fun. And it's definitely been born out of a response to a tweet that I wasn't expecting, and like anything that happens that's decent on social media, it starts off as sort of whimsical and sort of just a throwaway comment, and then some really interesting discussion comes off the back of it. If something good is going to happen on clinical social media and clinical Twitter, then it's usually something off the back of something sort of fun and lighthearted, and then not that it gets serious, but like there's some learning for us all to do, and it always, I love being surprised at how different people's takes are on different things. You know that about me. So I thought it'd be good to reflect on that and to chew it over. Thanks to those that tune in live, and apologies again for those that are trying to reach out in the normal ways that they would do during a live stream when they're attending and viewing it on, say, YouTube or Facebook or LinkedIn or whatever. Normally, you would post your comments and it would always aggregate them really obviously, and I would be able to pull the questions up on screen and we would be able to interact and chew it over together. Whilst I still really want you to try and do that, it's just some of them. And it's a problem that we're taking up with the developers, is that some of those aren't pulling through as easily or on time, etc. There's kind of a delay, or it's not shows me that someone's posted, but that not the details of it. So I've not been as interactive as I'd like to be, but that will improve. Especially they've promised me that by next week we'll be back up and running with that sort of stuff. So please do continue to, and I've been coming back to your comments on the various platforms afterwards, especially off the back of yesterday. We had a really interesting chat and loads of feedback from you on those channels, but I wasn't able to bring it in on the feed about the CSP's fee increase and the event that we're doing next week and stuff. And so you've sent over some questions and comments, and that's been really interesting. So thank you for that. Today, more of a clinical one, and I do love doing these now and again, and it's one that's taken me by surprise, wasn't planned, wasn't in the schedule, but have a look at this. If you haven't seen it already, this is an X-ray. Obviously, you want to be appropriately sensitive to, or whilst it's used with permission, the details of the case, that this isn't appropriate for me to go into or make it identifiable in too tight a circumstance. But one of the things that I posted this out on social media with was the caption was "Farmer asymptomatic standard," and it. Yeah, kind of caught hold. You can see there you've got about 1,000 interactions, or by the time I'm doing this, it might be about 1,000 interactions with it, I think, especially if you include the comments and that. So, there's a few things to say about that. I think that the people said that there's an interesting take that they wanted to hear more from me about on all 3 of those words. So it's a 3-word caption, but people want me to justify or explain myself on all 3 words. Why have I said that it's relevant at being a farmer? Some of you feel like that resonates with you, and others are just like, what you're getting at. Asymptomatic is a funny thing for me to say when I then unpack at least a little more detail as to the case, because asymptomatic would beg the question, why did you x-ray him then? And then, why am I saying that that's standard? What's the implication there? And so people wanting me to explain myself. I don't think necessarily because people are failing to understand what I mean, but just like they wanting to know my thoughts and my take on it. And that's what it's good about, commentating on this stuff. And so, yeah, if you haven't seen it already, or if you're tuning in like done before, and hopefully you can get through to us. What do you think of that? What's your thoughts on that, Nee? Feel free to post, even if it's just emojis. Let me know what your thoughts are on that knee X-ray, and we'll talk through it. Now, I'm not going to talk through it in terms of like a graded analysis of that knee. That'd be hilarious. I don't have the technology either to put like a cursor up and say, well, this is where the joint space should be. So we're not quite doing that. I think it's fair to say most of you watching this show will know that that's not how a knee's meant to look, shall we say, or that is a fairly severe degeneration and what is clinically known as an obliterated knee. So where to start? Well, the story goes is that there's a farmer who's a former patient of mine, and he presented having been, classically persuaded by his partner, having tried to get into a machine. I think it's not a stereotype. I think it was like he was trying to get into the one of the parts of his combine or something like that. Right? He's trying to get into a machine to try and fix it, and he couldn't flex his knee enough. It's just like it's sort of stuck, not stuck and fixed, but like couldn't get enough flexion. And that was what was annoying for him. He couldn't get into a position that he could have done 6 months ago when he was fettling the same machine or whatever. He's like, that's annoying. But it was pain free, and it didn't give him any. It wasn't like it wasn't pain, but he described a really uncomfortable stiffness and aching or something. No, he didn't have any discomfort, let's say, from that knee at all, and he noticed that it just wouldn't flex enough. Now, this is where I want to just clarify: is that second word on my caption, asymptomatic, is not the right word now, is it? That is unfair. The lack of range of movement and the functional limitation is technically a symptom, isn't it? I think if he'd have come in for his left shoulder, and I've then assessed him and noticed that his knee is, say, angulated and gnarled and stuff, which it was, and I'd noticed that without him presenting it with that as a functional limitation would be a symptom. You could argue that it might have been asymptomatic, but that's a clinical sign that I've observed. I think on the technicals of it. And so I just want to make sure, for those that need me to, I did misspeak, I think, technically, and apologise, because it's not that it was asymptomatic. It's just that I think I'm using that interchangeably with pain-free. And I think that's possibly, for some people, they wanted me to admit that that's clumsy. And I think they're probably right. I think it probably is clumsy for me to say asymptomatic. What I was meaning this was pain and pain-free. And when I say it wasn't stiff, he didn't say my knee's stiff. He wasn't describing stiffness. Of course, it was stiff by some calculation when you assessed it, but generally speaking, it was otherwise pain-free. Wasn't full range movement. That's the thing. People saying, "What's his range like then?" And when I described this a bit more to the context of the story, they were wanting me to clarify that, well, that's a symptom. So apologies for that. But yeah, I think it's interesting that for many in our game, we kind of know that you need, symptoms don't correlate with pathology or what have you. But that would surprise many that wouldn't hurt or be giving him much jip or significant, let's say, functional limitation beyond the knee flexion that he needed to get into a machine. So apologies for that. Now, what's the farmer bit? Like, people saying, why are you mentioning farmers? Or some people just taking it as being like really familiar and saying, oh my God, yeah, classic farmer. And so we've had a bit of a mixed bag there. I'd say most people sort of getting what I'm meaning by that. Don't think I'm being, by the way, I'm not saying some people are offended by it. I've not met anyone that's online saying like, what are you getting at farmers for at all, or being unfairly stereotypical. Maybe come at me if you feel that is the case. I'd love to hear that analysis, really. But I haven't heard that so far. It's not people saying being sensitive or feeling like I'm being insensitive about farmers. It's just that there's a few things that are fascinating about farmers, and a few others that have said the same, really. And I had a lovely reply, I forget who it was from, just now, that says standard in Cumbria. And it's like, well, yeah, rural areas and rural counties and stuff, people have been in touch to say, oh God, yeah. And when a farmer presents, then you know something's wrong. A few things then that I want to just reflect on there. And it's not that every single farmer's like this, God's sake, of course not. But they tend to be pretty hardy because they've exposed their body to quite intense conditions. Doesn't mean that they're tough inherently, or I would argue that it's not necessarily that they are conditioned or primed to feel either less pain or be more resilient or whatever. But just as a general rule, the nature of that job means that there's somewhat antisocial and somewhat uncomfortable hours, exposure to weather, positions, challenges that you've not got health and safety on site. If you can't find your hammer, you might use your fist. They're just a bit gnarly. And I'm playing to a stereotype, and I think there's a generational thing there as well. It's like farmers my age and younger have kind of come on, would challenge some of that and be like, we're smart now, Jack. We use technologies, and we recognise some of the mistakes that our fathers and their fathers made with pushing themselves too hard and stuff, and we work smart shifts, and we've got more technology integrated with regards to, say, feeding if it's cattle or machinery. We've got mobile mechanics now that we don't have to do everything ourselves. So, I properly hear that, and I'm in touch. I'm from a relatively rural area, but it's for kind of a good mix, really, in that sense. And so I think that I would argue I kind of am in touch with that a bit to know that it's not everyone, and it's justly relevant. But the farmer bit is really interesting as well, in that they're often self-employed, and there is certainly there's no such thing as light duties. So they put themselves through, regardless of what pain they might be experiencing or discomfort or colds or coughs or whatever, they are going to show up. And if they don't, then it's not just the consequences that exist where most people, self-employed tradesmen or even self-employed physios, of course, and you think like, it'd take a lot to stop me turning up from work, and that the argument that, my pay depends on it makes a big difference. With farmers, I've always found that it's a bit more than that. You hear that from builders, from roofers, from plumbers, from physios, self-employed. Then, if I don't show up, I don't get paid. And that's a factor affecting presenteeism, the act of turning up when you possibly shouldn't. But with farmers, it's the consequence or the sequelae from that behaviour. If they weren't to turn up, I say behaviours, it's always voluntary. It's just like, if they don't show up, it's like that might have been a crucial time for, if a lamb dies, I know it sounds dramatic, or if the crop needed to be, the harvest needed initiating or whatever. I don't know enough about farming to give you all the examples, but having heard it from various patients that have ended up in a funny spot, not just because of an OA knee or a low back pain, but people that are farmers that have broken a major long bone, that then you're trying to get them to modify their duties and they're in bits, often sharing a deep vulnerability to say, I don't know how we're going to survive, as a business, if in this week and only this week it could be done. We need to do this. And I would normally be working 120 hours a week. So I really think that that's why I'm describing the uniqueness of farming, is that there's some of the stereotypes I'm letting play out with regards to what that involves, but also the work dynamic around what they will do is a fascinating one. So that's why I'm saying farm and I'm saying standard. And I'm also saying that when me saying asymptomatic, and by what I mean, and I've clarified now, is that it's pain-free, is that you can't, for me, I can't ignore that this is, it's a shame, isn't it, that I can't point at it, can I? Or like I get a cursor or something, that would have been nice. You can't argue, or I can't argue, that there isn't a pattern, and that you could see that knee could have been anyone's. But when you tell someone, tell most clinicians that it were farmer, the amount of people are like, yeah, you can kind of get it. I remember a story, it's great one, not a great outcome, unfortunately, but like a farmer that had diabetes and had some sensory loss in his feet, and he dropped his keys in his boots and not noticed because he'd lost the sensation in his feet, and then chewed all his feet up because he dropped his key in the side of his loose work boots and stuff like that. And it's just like that, you hear of those stories, and that's not a sign of toughness because you can't feel them, and it's sort of a really unfortunate thing that happened to him. But you can imagine that there's just this sense of sort of gnarliness, with a word that's better than that really, but like a hardiness and a toughness and a resilience and a just general, there's a stoicism as well. I don't know if that's a British farmer thing. They say that the British are stoic, and they say that that's somewhat stereotypical of a British working class man as well. But yeah, for farmers, they just tend to be the presenting to healthcare, and probably for, I'm not lauding this behaviour necessarily. I think there's some great upsides to it in some ways, but unfortunately, in this instance, which I'm going to come on to, I've been challenged on what happened. People interested in the story, and I think in this instance, it is a shame if there were ever indications, or if ever anyone would have cast their eye over this sooner. I think that it could have been a better outcome for it. Not that you could have necessarily stopped the progress of the OA as a disease process, but which I'll come to in a second. But anyway, I hope that clarifies. And for those that are listening now, or for those that have been interacting with me on social media about this, then please Let me know if there's anything else you need me to do to put my words back in my mouth with regards to asymptomatic and why I was talking about farmers and why I was saying it was standard. You know, it was so funny that only a 3-word caption, but apparently every single word of it was controversial to some. And as I say controversial. You know, no one was being pissy or anything, but just quite rightly saying, "What do you mean by that? And can you unpack it?" So here I am unpacking it. Now, one of the big things really that I wanted to get stuck into then is that one of my favourite jobs and roles, especially when I was able to do it part-time whilst working on other things in my business where I might see some more acute, some sportier stuff here at Choose Health, is that when I worked in advanced practice in various different locations, and the amount of sort of problem solving and the sort of more skills and tools available to me, including requisition of imaging, such as getting people to come in, and the ability for me to say, I'm going to get that X-ray and send them downstairs and stuff like that, which you have in private practice, but it's just slightly different. And then when you worked in, say, a hospital environment or in a minor injuries clinic or whatever it might be in A&E, and so this guy presented because he couldn't get into this machine, as I mentioned earlier, and otherwise was pain-free, somewhat reluctantly trudged in, his description, nagged by his wife to get it looked at in case there's something he needs to do, because I want it to bend more than it does and I don't want it to get worse. And at that point, he was being totally understanding. He's like, oh, and he was saying, I said, has it ever hurt and stuff like that? And he's like, oh, not really. And he's just like, I think in part he was sort of describing, well, no worse than any other part of my body, really. And he was in his early 50s, from what I recall. And he was saying that, ideally, I don't want it to get worse, and it doesn't bend as much as I'd like it to. I think as well, from what I recall, he recognised that it were a bit of a funny shape and that there was something going amiss with it, so he wanted it looking at. And so I assess him, and the big thing really for me is that it was pretty angulated, and that change in the way in which you can't see as much from the X-ray. I'm sorry, I don't have the other view to hand, but that the rotational aspect of the tibia. So if you see where the fibular side is on the lateral aspect of this on the left knee, that the fibula, the lateral aspect is kind of towards us, and the tibia rotated away. And what would that be? That would be sort of a medial tibial rotation. So it was quite angulated. Apologies for those that are tuning in just to the audio, by the way. You've got a treat when you find this X-ray. It's all over my social media, and you have to find the video for seeing this. But yeah, basically a pretty gnarly O&E that you're looking at there, obliterated joint space, which is somewhat surprised to some people that it was pain-free. Now, what transpires then is that I'm then assessing what is a pain-free knee. And to some people, they're then thinking, well, why do you X-ray it then? And for me, having described what I've just described, whereby it's got a significant restriction in range of movement, of flexion and terminal extension, and that there's clearly visual deformity that was then affecting gait mechanics and beyond, really. And so, to me, that's plenty indication enough, and arguably symptoms and signs for me to want to understand what that looks like on X-ray. Now, when I've said on social media that if someone had have this knee had have been, say, he'd have cut himself on his quad 3-4 years prior, and he's gone to get stitches on his thigh, and someone, therapist or otherwise, had seen his leg and noticed that knee, I would argue at that instance, oh, that's a funny looking knee, ask some questions about it and potentially got some baseline imaging done. And this is the bit that seems to be contentious for people. It's like, what are you going to do about it? Why would you bother? Why scan someone unnecessarily? And what I'm getting at with this is that if you've got something that we understand that pain's not relevant to, it's not always a good proxy for damage is not a good proxy for pain, etc. But if, say, you notice something that's quite visually deformed in such a way that then isn't a secondary to polio or CP or something that's kind of known to the person as being, whilst they need to be managed carefully as well. I'm just meaning that this isn't something that, this is my bad leg and this is my story, lifelong story in history from an ORIF 20 years ago, or whatever it might be, or some other disease, is that this is something that, like, that's just my leg. Yeah, it's a bit funny, but I've not really thought much of it. If it's a professional, you're looking at that and think that's unusual. If there isn't a really obvious story there, that's unusual. Then I think you should engage someone in conversation about it. I would say that in this instance, with the knee we're talking about, that your problem you have is that if this does flare up and become painful, or it deteriorates to the point of it being really dysfunctional on that, intrusive on someone's function and ability for them to say work. And I don't mean getting into niche machines. I mean, like, if this was something that took a turn for the worst and was really affecting his ability to do sit to stands or whatever. Let's say we could even argue that he broke his leg on his other side, or he ended up spraining his ankle and stuff, and it's really difficult then on a semi-weight bearing leg. If he then shifts his weight over, it could flare up his symptoms, but it also could arguably, how to put it, just ask too much of his range of movement to get himself up off a chair. If he needed to, say he was on a cricket, let's just say he was on a cricket pad splint on the other side, and he's only got sort of 50, 60 degrees of flexion, I can't remember exactly, on that side now. He's not getting his leg underneath himself to do a sit to stand on that leg, no matter how strong and hardy he is. And so I suppose I'm admitting that regardless of whether it's painful or not, when things are quite as overt as they are, both visually and its functional limitation that had emerged from it, or what might be a resultant functional limitation that's likely to be downstream of that sort of potential degeneration, bearing in mind we're not seeing an x-ray at that point, I think getting that baseline imaging is very valuable. And the main reason is, and my understanding from working with orthopedic surgeons, and some of the commentary from what I haven't had this counted necessarily from the orthopods that have said this on social media, is I think that the indication for getting an understanding of what that looks like radiographically is because there comes a point where surgeries are far more challenging. Doing a total knee replacement on that knee, from what I understand, is a far more challenging exercise than it needs be. And the alteration of the sort of limb angle, the joint angle, and things like that is more of a challenge than it needs to be. And that if you're imagining a circumstance where you need to sort of monitor that over time, and you notice that it's deteriorating quickly, but the symptoms might not be, then a timely knee replacement might be, on balance, something that helps this farmer work into his 60s than what he was potentially facing down now. Now, it doesn't mean that I'm looking at this and because he hasn't had that before, I'm looking at it and saying, right, it just needs listing for surgery. No, it wasn't a direct listing type circumstance, but it was certainly something that I wanted to get an orthopedic opinion on it, and for us to balance that risk and benefit, to just be open with the patient about what the future might hold. It's something that, is it likely, in my opinion, that person with that knee and that occupation is going to be able, without some sort of care and potentially some sort of intervention, live out the life that he was planning to live and retire at the time frames that he was planning to retire? No, I don't think it was. And it was a challenging conversation, but one that I needed to be informed by my orthopedic colleagues on, and to get the appropriate workup for imaging to do that. And so for those that are surprised at the fact that you would image a pain-free knee, these are circumstances that I absolutely would. And I think that the signs and symptoms that we had noted on assessment and from what we're observing, I say we because that became quickly a team effort, is one that certainly was much more relevant in many ways than, say, pain would be. It works both ways. Is that pain, because it's not always an accurate representation of sort of damage and severity, means that sometimes it's the signal's not just always too loud. Let's say, people talking about sort of signals and alarms and stuff, right? People thinking that we often talk about the fact that your pain might be high, but your damage might be low. It's like your pain might be low and your damage might be high. And if that damage is sort of going to be something that has any consequences downstream, like structural obliteration of a joint, etc., then we can't say that the pain's suddenly primary. I feel like that's where it ends up being a bit hypocritical. Whilst I understand the underlying reassurance that can be offered by people saying that the structure doesn't equal pain, but you're giving pain too much of a primary role in every decision if you're then thinking that if it's not so, the only thing we're bothered about is pain. It's like, well, it's not, is it? Because we're often trying to persuade patients the other way. I don't know if I don't know if you agree with that sort of analysis, or you think I'm there's a risk that maybe people think I might be arse covering a little bit on this, where I'm justifying post hoc my decisions, and there might be a bit of that. You never know when you are doing, but I think on reflection, I'm fairly happy enough with how things ended up. And in this instance, a few months later, I mean, one of the difficulties was that once he knew about his range of movement deficit and stuff, he couldn't help but try and work it and force it and stuff. And so it ended up becoming a bit more painful in time. Not because he'd done that, you never know what the future would have held without. But once he knew about it and stuff, and he'd met me and we were trying to get him in front of the surgical team as a joint assessment and stuff like that, you end up in a funny spot where he ended up sort of working it into more flexion and stuff, and he needed to get into that machine, and then it started to become a bit grumpy. And once it's done that, it was then in a really funny spot where there weren't a lot of options available to us if it was to sort of flare up and start to get him limping heavy or whatever. And then it was all about sort of timing for what intervention might be appropriate. So in the end, he did have a version of a total knee replacement, and a happy ending following that. But it was a much more, from what I understand, a much more complicated surgery than it needed to have potentially been if people had have sort of acted on it a bit sooner. Now, there weren't obvious instances where they could have got ahead of it. It's not like he'd seen a colleague 3 years earlier who documented something interesting but hadn't imaged it or anything like that at all. Right? This is absolutely I have no one in the story that I can call on this at all. They might have been there, but I don't recall them, and I don't remember him saying anything like that. And I think he hadn't presented necessarily with it before. I'm just meaning that I think a lesson I'd like us all to take from it, and something that I'm fairly confident was the right call in this instance, is that when you're presented with something like that, the fact that it's asymptomatic or pain-free doesn't mean you might not consider what the likely outcomes for this, what might happen, what are the different trajectories, and have you had an open, shared decision-making type conversation with the patient about what the future might hold, and try and base it where possible on your understanding of the evidence. And for me, I'm sat here not talking about the no doubt literature that I should be able to bring to bear if I was a smarter man in this topic, and I will, I think I'd be interested to read more of that if anyone wants to signpost me to it, but I will do a bit of a lip search, I think, at the weekend about this sort of stuff, because it could well be that I'm not informing my opinion as well by the harder evidence, but certainly from my experience and my working with some of our orthopedic colleagues, they've always said before and since this, and in this case, that you don't want to sit on these sorts of things for too long, or that you shouldn't be sucked into being reassured significantly by the lack of symptoms, as if that's the only thing that matters. Because if they're ever going to need to run a scalpel on these people, especially with active occupations and huge social consequences to a prolonged inactivity, then they want to see them sooner. Because one way that it was put to me is that if it's the difference between them being able to replace a joint and then give them full weight bearing status next day, and the difference being that they're needing to do some sort of, we've had telespatial frames that have been required for a period of time prior, and then even, which I know are typically weight bearing frames, but then certain really complicated orthopedic protocols for bracing, etc., that means that this like partial weight bearing status that's required for a time whilst this bone union going on, grafting, those sorts of complexities in a person with an occupation such as a farmer, they want to try and avoid that. And so if they can have those sorts of conversations sooner on joints like this, they want to. So please, I would say, until I'm corrected otherwise, I would say that in these instances, I think it's smart for us, those x-rays, and to understand what the state of play is with the tissues, and to not ignore those things, even if they're not hurting. Reassuring in many ways, and people might want to use this example as being like, this knee didn't hurt, and therefore reassuring people with lower grade OA that needn't be their destiny. But also, we don't want to use x-rays like this to scare people that is an inevitability of OA as well, because of course it's a niche circumstance, and I can't recall what's in this guy's past that might have preceded it. But really enjoyed sort of unpacking it with you today, and I really do appreciate all of you for contributing and commenting over on Twitter. I think did I post it up on LinkedIn and Insta as well? But yeah, it's been an interesting one to see all of your reactions. Thanks a lot, and I'll see you all tomorrow for more Chewing It Over. And if you haven't already, then do have a look at yesterday's show about the special event that we got next week about the CSP for the fee increase, as well as, of course, so giddy about this, absolutely giddy about this. And this is what we'll be talking about tomorrow, is the agenda for Therapy Live Sport, which is gym sports this year. And it's an absolute who's who of a program, as well as some of the best content balance I think we've ever done on a clinical show. So yeah, last few tickets available for that. Very excited. And I'll speak to you all soon. Cheers, Ed.